Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. All right, so Dr. Jeff Dikis out of Des Moines, and I guess unfortunately Dr. Leland Jaffe couldn't make it from Chicago, from Jan's old stomping grounds. All right, so tendon transfers. Just a couple things I thought was interesting. I borrowed this from the BOFAS. They put together some nice talks on tendon transfers. And when you think about tendon transfer requirements, there's several things that we kind of have to stick through. And that's like, mobile joints, soft tissue equilibrium, the ability for the donor to excurt, donor strength, expandable donor. The line of pull has to kind of match what you're transferring to, the synergy of the muscle, and then this usually kind of just getting one function out of the tendon transfer. So you'll maybe hear us talk about these things. I just wanted to bring them up as it relates to some of the cases that we're going to talk about this evening. Okay, so first case, this is a female patient presenting in her late 40s, early 50s. She comes in complaining of right-sided medial ankle pain and swelling. She has a past medical history significant for hypertension. And when you kind of talk to her, you think, you might have some pre-diabetes going on too. She works on her feet. She doesn't smoke. She's, kind of works in food industry and, says that at the end of the day, her inside part of her ankle is just killing her. So on her exam, she's got a little bit of bogginess on the posterior medial ankle. She's got a little bit of a flat foot. It corrects with passive inversion. And she has about a 10-degree equinus contracture. So it covers kind of a lot of things we see. So right-sided ankle pain. These are her plain films when she comes into clinic. I like to get a Saltzman view to kind of look at alignment. Jeff and Jan, are you guys using Saltzman views at all in your clinic?
Yeah, I think that's important to look at the hind foot in relation to the, you get a decent picture from the AP view there with the tailor head uncovering, but the hind foot view can potentially skew your treatment algorithm in terms of, associated osteotomies. So yeah, I think that's important.
So when we talk about looking at this, you mentioned it briefly, Jan. I'm trying to bring up my, be able to draw here, but the tailor uncoverage, here we're looking at the tailor head, and then we're looking at the navicular, and we're looking for the amount of uncoverage of the navicular relative to the talus. And then what are you looking for, say, on the Saltzman view, which is the image here on the right? What kind of things are you guys looking for, Jan and Jeff?
Yeah, I'm just looking to see where that heel is in relation to the tibia and how much
So,
valgus is.
so you're like center point, like do you draw a line down the tibial axis and then kind of see where it lands? I can't draw it really straight.
Yeah, I probably should be measuring it. I don't. I just kind of unfortunately look at it and it gives me like a rough idea about what's going on. Because most of these patients, if you're going to do any type of soft tissue reconstruction, are going to require an osteotomy here.
Okay. What about on your, so we got our AP views, and then what about our lateral view? What are you all looking for on the lateral view here?
So specifically, I usually look for any kind of that midfoot sagging, either TN or navicular-cuneiform joint sagging. And if there is, I know that the deformity is a little more advanced than maybe soft tissue tendon transfers would allow for, but sometimes you'll see some of that midfoot arthrosis and the sagging at the TN or the NC that kind of tips me off where the apex of deformity might be in the sagittal plane at least.
How does that influence your decision making for, like, if you're considering surgery? So this patient's, we'll just kind of jump through the non-operative stuff. I know we could have a whole discussion on non-operative modalities, but let's say she's come to the point of wanting something done. How does the talonavicular and NC joint influence your decision making when it comes to talking about surgical intervention?
I think I'm much more likely to jump to some sort of, well, it depends on a few things. If I can mobilize the deformity, if it tends to be more rigid. If it's more rigid, I'm going to jump to more of a fusion status. But if there is that midfoot fault, then I know that I may have to jump to doing something more along the lines of an Evans or a Cotton to try to correct some of that sagittal plane deformity that's assuming that there isn't a lot of that arthritic change at the dorsal aspect of the joints. If there is, I'll get an MRI and I'll look at the joint itself and the cartilage and see if there's any erosions or subchondral cysts. If there are, that's going to change my plan significantly. So if I do see that midfoot fault, I'm paying attention to specifically those midfoot joints and seeing how much destruction there is, which will help skew me towards either fusion, maybe reconstructive osteotomies, or whether if it's flexible and it looks kind of similar to this, be more amenable to just a soft tissue involvement there.
I got a question for both of you. Do you guys have any age cutoffs with like between flexible reconstruction and more rigid, such as a fusion?
I don't have any hard and fast.
What about weight?
Yeah. I mean, I think we would all say that we'd probably skew towards more fusion status with the more morbidly obese patient is going to tend to fail with the primary tendon transfer. So I don't have a specific hard and fast cutoff, but obesity is going to tend me towards fusion status. What about you, Nick?
So yes, I will. I don't have exact, weight cutoff, but if they are flexible, but they're bigger or a little bit older, then I'm more likely to add a subtalar fusion into the plan. And so at MDCO with a subtalar fusion, still doing a tendon transfer, if they're flexible, and I've been pretty pleased with that kind of construct for that bigger patient. Jeff and Jan, let's just talk real quick about staging of these, because we kind of talked about it briefly, but I think it's important when it comes to tendon transfers and the, progressive collapsing foot deformity or posterior tibial tendon dysfunction, depending on what annotation you want to use. But like a flexible versus a rigid or something that's more degenerative. How do you kind of, I mentioned it before, but, the idea being that it is a correctable deformity. And you kind of mentioned this, Jeff, when we were talking about the exam, that being able to correct them makes you think more of a tendon transfer as opposed to something that's more rigid. You're thinking more of a fusion. Am I understanding that correctly?
Yeah, I mean, I think it's kind of a scale from tendon transfers to tendon transfers plus osteotomies, whether it's a displacement osteotomy, the calcaneus and Evans, a cotton, whatever it may be. Then on the final end would be more fusion status. So yeah, I think that's reasonable.
Jan, anything to add to that? Because I think we want to make sure that's clear of when we're talking about tendon transfers with osteotomies or joint preserving, maybe.
Yes,
globally
I
speaking.
would agree with that.
Okay. All right. So here's our MRI. Hopefully this will see if I can get this to play without music. All right. So here's our axial on the top left, maybe. There we go. So you can see the medial side is on the right, and you can see all this fluid here kind of along the right side of that screen. And the tendon gets pretty thick as you look more distal. I don't know how well that's showing. Here's the coronal. Cursor's on the medial side of the ankle there. You can see kind of that thick bogginess about the posterior tibial tendon. Then I got a sagittal image here too. Kind of skipped ahead, sorry. There you go. You see the tendon get kind of thick. It's going to come back into view, I think, here in a second. Yeah, maybe not. But try to pull it back here. Right there. You see kind of some thickness about the posterior tibial tendon, some fluid that's around it. How are you all using MRI in these cases here to make a decision? Or maybe it doesn't matter. Maybe it just confirms the diagnosis.
Yeah, I'm not using it very often. Many of them get referred to me with an MRI, I would say, because it's someone gets an MRI because they have foot pain, and then they says like posterior tib tendon tear, and so they get referred to me for tendon tear and for a tendon repair. But I don't use MRI for this unless it's something specific, like Jeff mentioned, like if looking for some cartilage lesion, like their pain's atypical. And I'm just like, I'm looking for something else. Like, hey, they have some flat foot, but their pain is just not what I would be expecting right now, or some of their symptoms. So then I'll order it myself.
Jeff, how about
Yeah,
you?
yeah, I think I agree with that. Or I know I agree with that. I think it's mostly of a confirmatory status. Like I said earlier, if you find any kind of erosions, if you see it, you can kind of predict it. If you see it on the X-ray where they have that NC navicular-cuneiform fault where it kind of comes down and then it kind of forms a little V on the top, you know that there's going to be cartilage irregularity. The joint is no longer perpendicular because of the fault, and they're going to start to get some cartilage erosion. You can evaluate that with the MRI. I don't know that an MRI would potentially change my treatment algorithm, though. It's mostly confirmatory for me. What about you, Nick?
I think it does help with, looking at the joints from you mentioned that earlier, especially if I'm looking at the subtalar joint and I'm thinking about potentially adding that into the fusion in terms of my reconstruction. I do think it helps when I'm looking for, sometimes I'll see articular injury to the articular damage into the tibio-talar joint. So sometimes that could be a cause of pain. Occasionally I'll find somebody with osteochondral lesions on the medial side. So kind of be thinking about that, particularly if they're having medial ankle pain. And then spring ligament. I mean, I'm going to be looking at that anyway, but I think that's something we talk about, in terms of some of these reconstructions as well. So those are the things I try to look at. I'll be honest, it's a little hard for me to fully assess the spring ligament on the MRI when I'm looking at it. I'm kind of relying on the radiologist. But kind of, at least in my head, I'm looking for those things.
I agree with you. I don't think I've ever seen a spring ligament, tear or attenuation. But if there's, fluid, if there's signal uptake around it, then maybe that it's under undue stress. You can find a little edema in that
Yeah.
area. But I agree with you. It's hard to evaluate the ligament.
All right. So I'll skip ahead back. All right. So she's failed all her non-op management. She's interested in surgical options. She's got a flexible flat foot. How are y'all managing this? What's your guys' approach to this patient? Doesn't have a ton of uncoverage. She's got posterior tibial tendinosis with some fluid around it. Doesn't look awful, but maybe not totally normal either.
So I think I know the answer because I saw the title to the presentation.
Feel free to disagree. Feel free to disagree.
Um, but no, I mean that's very reasonable. So, tend to transfer FDL transfer. But I tend to augment my FDL transfers, and we can get into that with some sort of protective osteotomy. She didn't seem to have a whole lot of sagittal plane deformity, none of that midfoot fault. So I think we can skip the cotton. But I tend to do, in this case, maybe an FDL transfer, evaluate the posterior tibial tendon, debride any thickened, scarred, non-viable tissue, maybe tenodese that to the FDL, depends on what it all looks like, but then protect it with a medial calcaneal slide osteotomy typically.
Yeah, so that's kind of, I mean, that's how I approach this case. Jan, what do you think? I
Yeah,
mean,
very, very similar. I mean, I'm quick to fuse though. I'll tell you right now, I'm especially like I don't have like an age cutoff, but I've noticed like in just older patients, which is just a gestalt, no exact age, that I'm quick to fuse, and I have not been as happy with flexible reconstructions because I mean, say if you're dealing with like a 50-year-old, that tendon's 50 years old, even if you transfer the FDL. Like, I mean, so I don't know, like but that's the same algorithm I have, but I kind of reserve that for younger patients, I would say. But how are you doing your osteotomy of the calc? Are you doing it MIS? Or are you doing this, traditional kind of open?
So I still prefer a little mini open approach with the saw blade. I feel like I can get a much straighter, flatter cut with a saw blade than with the MIS burr. I don't know. I stick the MIS burr in there and it wants to kind of like zigzag. It's just going through that cancellous bone like nothing. And it's really hard to keep that really flat. So I don't typically have a problem. When I think of MIS, I think, is this is the difference between MIS and a mini open approach really going to help the patient in some way? Is it really going to change their outcome somehow in terms of skin healing and infection risk? And if I think no, and typically I don't really have any healing issues with that incision on the side, so I typically still do it with a little open and a saw blade. What about you guys?
I'm the same way for this. I do like I would say midi open or whatever. I've not had, knock on wood, too many wound issues there laterally, or anything. And you're not really putting hardware. Like I fix it with screws.
Mhm.
So I'm not having a plate there or anything. So even if there was a wound issue, I mean, it could probably just heal by secondary intention. So, but yeah, I'm with you. I think I'm a little old school with this. It just gives you more control.
I'm MIS all the way. I'm fully adopted on the calcaneal osteotomies, and I would agree with what you said, Jeff. For these, I don't know that I think it's dealer's choice. I really do. You don't have another incision on the lateral side. I do like it when I mentioned earlier, doing a subtalar fusion. It is kind of nice to not have, both this and then a sinus incision. So that part I have liked. Or if I'm doing like a lateral slide with perineal work or a collateral ligament work, that is nice to, to minimize those two skin bridges. But for this one, I think I really think it's dealer's choice. I don't think it matters one way or the other, in terms of how you do it. And the advantage of the open is you can kind of shave it down. You can, minimize the ridge on that lateral side, where it's a little harder to manage that with the MIS. But this one I did MIS and got a pretty nice shift on her. So that's my steps are gastroc and then the slide, and I'll do that with the tourniquet down. And then I'll go to the soft tissue work. I don't know if you guys do a different algorithm or if there's a different, rationale for steps through the procedure. I'd be interested to hear how you guys approach it.
I would agree with you. I tend to work kind of proximal to distal, posterior to anterior. So I would agree
Yeah.
with that.
Okay. So we all agree we're going to do some sort of osteotomy. We're going to get to help improve the alignment. How do you sell this to the patients? Like I mean, whether it's selling an osteotomy to the patients or even like the other day, I was at this case, I think the tech was the X-ray tech was like, why are you doing this? And I thought, well, of course we do this all the time. It's so common sense, but how do you sell it to the patients when you're talking about, hey, it's a bad tendon. It's not my heel. Why do you want to cut and shift it?
So I try to sell it the opposite way. I say we can fuse your entire hind foot. We can do some sort of radical, huge surgery, or we can do this. So I think it's all about how you frame it. And if you kind of explain to them, I mean, most patients are pretty reasonable. If you kind of explain, hey, here's what's happening. We kind of need to protect this tendon. You know, I don't want to say they trust you blindly, but there's a reason they came to you. They trust you. And so as long as you have a reasonable explanation, I've never had anyone kind of question it.
Yeah, I mean, I'll sometimes use the tire analogy. That's, one of the things if, the reason the tendon's bad is because your foot was, putting a lot of stress on the tendon. So we're shifting the heel to try to improve the alignment and take the stress off of it. I did a little bit, not a deep dive, but a little bit of reading into some of the historical text on, posterior tibial tendon transfers and why we started adding calcaneal osteotomy. And I mean, just like really briefly, the interesting thing is it was Meyerson and Schoen in 95, I think it was, that they wrote the article on addition of an osteotomy, calc osteotomy plus the tendon work. Whereas before that, the tendon work had kind of been reported by, and I believe it was, I think it was Roger Mann that had reported kind of, not great results with just tendon work alone. And so, that was why the osteotomy was added, is because the tendon transfers or tendon reconstructions in isolation really didn't do that well. So now we take it as being fairly common that, hey, of course it's what we do because it improves the results. But I think if you put it in that light, I think they tend to understand a little bit better.
So will you walk me through your technique there for the MIS calc slide? Are you going center and working your way dorsally and then plantarly and then leaving the cortex to the very end? Or where do you start with your MIS burr in that osteotomy?
So I'll first off, I'll mark out everything under an axial, which my direction of my osteotomy is going to be. So I'll do an axial view, just kind of marking out the direction of the burr. And then I'll mark out the osteotomy, including the center of where that osteotomy is going to be. And then I'll mark out the lines for my trajectory, for my superior and inferior part of the calc. And then I'll just do like a 4 quadrant technique where I'll go in all the way into the far cortex. So get through both cortexes, and I come back and I work my way up to get the first quarter, work my way down to get the bottom, the plantar quarter, both on the the lateral side, and then I'll go to the medial side, and I'll do that same thing, trying to work that trajectory, and try. I check a lot of X-ray as I work through there to try to keep it as, like you said, it can travel all over the place, and if you're not really dialed in, you can kind of end up in different places. But this one turned out really well, I thought, but certainly have other cases that turn out not quite as clean of cut.
Yeah, this looks great because I've seen some where it's just kind of like a little zigzaggy
Yeah, it ends up
line.
zigzagging.
As long as it slides, I guess it doesn't really matter, but
Yeah.
this looks great.
Yeah. And one of the things that I was always concerned about when I started this, I know this is on MIS osteotomies, but the burr takes a little wedge of bone. So I think it helps the translation a little bit more than I thought it might, as opposed to a saw, which is a little bit less bone that it takes.